And go. All right. Hello, everybody. Welcome to the daily recap from ACR 2025 in Chicago. I'm Mike Putman. I'm a rheumatologist at the Medical College of Wisconsin, and I am very excited to be hosting the Room Now Daily Recap panel for day four. This is the last official day of the meetings. This is an exciting time. It's been a great meeting, a lot of fun. Had a great time seeing all the great science, catching up with a lot of people. Good experiences all around. And today we're going to be covering the best and most impactful presentations that we saw at the meeting today. So excited to dive right into it. For starters, I'd like to introduce our illustrious panel. Brian, do you want to introduce yourself?
Sure. Thanks, Mike. Hey, everyone. My name is Brian Jaros. I'm one of the adult rheumatologists at Northwestern, so didn't have to go too far for this ACR. I focus in vasculitis and medical education, and I'm excited to be here and recap with you all.
Love it. Thank you for joining. Very happy to have you. Akil, would you like to introduce yourself as well?
Yeah, absolutely. My name is Akil Sood. I'm a rheumatologist at Washington University in St. Louis. I have a specific interest in lupus and background in epidemiology and clinical research.
All right, great. Well, thanks for being here, guys. Excited to have you. The format of these is pretty straightforward. We each have picked a couple of our favorite abstracts and presentations and picked a couple of key teaching points. So we're going to go around robin and give a little feedback between each other as we go along. For starters, we're just going to get right into it. Brian, I hear you have something to say about the Yanaliumab data that was presented at the meeting. Yanaliumab. Can you tell us all
Try,
about that?
yeah, try saying that three times fast. Yeah, so I will kick us off with abstract late breaking 24. This is Ianalumab demonstrating significantly decreased disease activity in Sjogren's disease, and it's the efficacy and safety from actually two global phase 3 randomized control trials, which of course are cleverly named. That's Neptunus 1 and Neptunus 2. Um, so I picked this because, as most of us are familiar with, we're desperate for anything we can get our hands on for these Sjogren's patients to help with their symptoms, improve their quality of life. So I was excited to see right off the bat that this, improved disease activity in Sjogren's. Ianalumab is a afucosylated human IgG1. It actually binds the BAFF receptor, so in that way it targets B cells through kind of a dual mechanism. One is blockade of that receptor, but because of the way it's engineered, it also contributes to antibody-dependent cell cytotoxicity. And there are two kind of trials here, Neptunus 1 and Neptunus 2. The big difference is the dose of ianalumab that was administered. So in Neptunus 1, they compared ianalumab on a Q 1 month dosing schedule versus placebo. In Neptunus 2, they compared that Q monthly dosing to Q 3 monthly dosing to placebo. They recruited adult Sjogren's patients. They had to be diagnosed within the last 7.5 years. They wanted to get people who were, not smoldering for like 20, 30 years and unlikely to have a response. They had to have an SDI, which is that Sjogren's disease activity score greater than 5, indicating at least moderate activity, and some residual salivary flow. Again, I think trying to rule out people who just had like completely burnt out and just damaged disease. And the primary endpoint was change in that SDI. So when you look at the results from both Neptunus 1 and 2, you saw significantly reduced SDI in both Neptunus 1 and Neptunus 2 in the Q monthly dosing regimen. The Q 3 month dosing regimen did not meet the primary endpoint, so this does seem to be a dose-dependent response, that the Q monthly dosing is the one we're seeing in effect here. Um, what's interesting when you kind of look at the results more closely is that actually, and as is the case in a lot of our trials, placebo got also fairly high improvements in the SDI
Quite a lot.
scores. By a lot. Background immunosuppression was allowed, and a good portion of people were on background immunosuppression. So it's possible some of this was being driven by DMARDs and other therapies that they were getting. Even accounting for the placebo, there still was a statistically significant benefit to ianalumab, but both achieved a minimum change of at least 3. I think the mean was around 5 to 6 for both of them. So they're both considered clinically significant responses. They Also, I thought what was interesting, did a subgroup kind of analysis of the folks who had salivary flow greater or less than zero point 0.4 milliliters per minute. And in those who were at the higher end of that threshold, they saw an improvement in salivary flow rate, and that was corroborated by subjective improvement in oral dryness from patients taking it that they did not see in those less than zero point 0.4 milliliters per minute at baseline. Um, in terms of safety, pretty comparable between groups. No major safety signals that came out of the ianalumab treatment. Um, so
Yeah, I
for
was
me,
surprised. I was surprised
yeah,
by that. I thought it was better than expected. What do you think?
in terms of the safety signals,
Yeah, yeah,
completely agree. I mean, when we're extrapolating from other B cell targeted therapy, I would have suspected, especially with infectious risk, a higher rate of adverse events. Again, I wonder if because the placebo were also on a fair amount of DMARDs, which, have their own infectious risk, if that drove some of them in that group. But I thought this was exciting. I mean, again, we're seeing a few things, hot right now in Sjogren's. I think it's a really pivotal time for the disease state. And I'm pretty excited about the idea of this coming forward, as a possible treatment. I think the other interesting thing that comes out of this with that salivary flow subgroup is, do we need to be catching these people as early as possible before
yeah.
damage has occurred? If we do start them on this medication, will it have a disease modifying effect, which obviously we've struggled to find for salivary, gland
Yeah, big
target.
time. I love it. Akil, what do you think? Is this going to be FDA approved? And is there anything that stood out to you on the abstract?
I think that was a really interesting abstract and definitely really interesting findings. I think, definitely with Sjogren's and, the previous clinical trials is that we haven't seen it meeting the endpoints or this, the placebo effect that we are concerned about. But seeing when you adjust for placebo, we are seeing this positive response and definitely does seem like a promising drug for our patients with Sjogren's. But I think definitely will be things to consider like the timing of this
Yeah.
medication, especially, early Sjogren's versus long-standing established Sjogren's, missing that window of fibrosis, especially in those glands. I think, and especially that, that subgroup analysis, as Brian mentioned, was with the improved salary flow. I think that's definitely really exciting, and it'll definitely be something worth looking into, especially with Sjogren's patients when looking objectively, is that we start this ianalumab and see this improve in both subjective report by patients, but also even the objective findings as related to salivary flow as well. Definitely do think it is a promising, will be exciting to see what comes out of it with the next steps. Absolutely. And I think even going back to that safety, uh, I guess one thing was is that there was comparable safety profile. I wonder if it was the BAFF pathway because at least with belimumab, it does have the previous studies have shown that it does have a pretty safe infection profile. So I wonder if there is some component of that. While it is a B cell pathway, the infection profile, even in belimumab, has been relatively safe, at least in previous studies with the emulated target trial as well.
Yeah, I'm not a big science guy, but I think that it has a little less impact on T cells, maybe, but I'll have to look into that one more. I got a tweet for you guys. This is from March of 2019. I was talking about the preliminary data. I said fails primary endpoint, but shows significant reduction in fatigue in primary Sjogren's would be game changing, but we've been down this road before, and these effects typically wash out in phase 2 and 3. So the fatigue did wash out, didn't hit facet fatigue. So I was right, but they hit on their primary endpoint, so I was also kind of wrong. So it'll be interesting. I bet the FDA approves this, but it'll be interesting to see how it goes.
I think so.
Akil, you're up now. You were also excited about a late breaker, is that right?
Yeah, absolutely. Yeah. So I think, here at, ACR25, we've seen a lot of abstracts related to CAR T. I think since the landmark study coming out of Erlangen, we've just seen a rapid explosion of CAR T therapies over the last few years, and especially just the different formulation, the engineering. With the landmark study was looking at cytotoxic CAR T, CD19 positive CAR T. But late-breaking abstract 23 evaluated the safety and efficacy of of regulatory CAR T in patients with refractory RA. So with the landmark study, compared to the landmark study, they're engineering these regulatory CAR T cells that are specific for citrullinergic proteins, which is really important in rheumatoid arthritis, ACPA positive. And compared to the landmark study, these patients also didn't receive lymphodepletion. So it's a different approach in that we're not just one is the cytotoxic impact effect of CAR T on autoreactive B cells, but looking at the immunosuppressive effect of regulatory T cells on autoreactive B cells, and then also looking at, they also eliminated the lymphodepletion uh, factor, and then also they allowed patients to receive background immunosuppression up until the time of enrollment and including during the study as well. And so, well, this is an ongoing phase 1 study. It was a small cohort of patients, about 6 total, patients with 3 receiving dose level 1 and 3 receiving dose level 2. And they found really significant impact or reduction in disease activity measured by DAS28 CRP, with 4 of 6 having a decrease in their disease activity at week 4, with a more rapid onset in the dose level 2 in terms of both joint counts, tender and swollen joint counts. And they also noted significant improvement as well in HAQ-DI as well in terms of functional status. But the tricky part was that after week 4, we started to see some variation in terms of response. There's some patients that had sustained remission, but then there's another fraction of patients that had a rebound of their disease activity. So then it kind of leads to the question is that where is the effect? Where is the major agent at play? Is it the regulatory CAR T that is, that's the confounding, or is it the lymphodepletion as well that the patients aren't receiving, even the background immunosuppression? But when it came to safety, it did overall show a pretty safe profile with no reports of ICANS or CRS. So I think yeah, overall it was a pretty interesting abstract. Yeah,
Yeah, I like it. We're kind of getting more creative about the CAR T. Maybe I
absolutely.
think this induction therapy part of it, or the cytoreductive therapy part of it, has always been like kind of a tough sell for rheumatologists. So
Mhm.
I think a lot of folks are focusing on ideas that are beyond that. But,
Mhm.
we're also kind of losing the initial sort of this is all magic sauce vibes. And I'm wondering if we're kind of trending more towards a middle ground that'll be a little less inspiring, a little less harmful. I don't know. Brian, what do you think? Where does this fit for you in CAR T stuff?
Yeah, I have to say, I mean, I think this is furthering the landscape, certainly, into what we all want, which is hopefully curative treatment for our patients to get them off immunosuppression. Um, I worry that, like you said, we've exchanged the cytoreduction, which I completely agree is a concern, for something that seems like it might rebound, and not have that strong of an effect. And frankly, for me, and maybe, it's definitely possible, I just don't see enough severe RA, but the type of RA patient that I would be thinking about CAR T in, we're already in connective tissue disease vasculitis thinking of very specific people, but I would have a really high threshold in rheumatoid arthritis for CAR T. So I'd want something that's really safe and works very well, which hopefully we'll get to, but I don't know that we're there yet, if that makes sense.
Yeah, that's a great point, honestly. It's going to take me exactly one person who gets grade 3 CRS
Yeah.
before I'm just out.
Yeah.
And so it's kind of hard in RA. Your threshold for safety is going to be a little bit higher.
Yeah.
All right, great, Michael. I love it. All right, my turn. I'm gonna jump right in. So I'm gonna transition briefly away from the late breakers and share one that I found just a little bit ago, and I watched the presentation on it, and I just loved it so much. So I gotta share this. This is abstract 2662, and this is a target trial emulation of biologic and targeted synthetic DMARDs in RA ILD. And so this is combining two of my favorite things from the last year. One is target trials, and just a brief explanation of that for everyone. There's a lot of funky epidemiology at the meeting this year, a lot using the Trinetics database, and some of it was great. And all of it was well intentioned, but every once in a while I just said, I don't know about that. And so I have been looking for some really good epidemiology to share tonight. And this is Rishi Desai's group. And this is Gregory McDermott. I'm a guy who did a really awesome presentation and a really cool study here. So this target trial ideas, they say we're going to do observational data, but we're going to try and make it look like an RCT. And we're going to try and approach some of the rigor that you have in an RCT, where, you have a well-defined patient population. We're excluding a whole bunch of people to make sure that we were really studying the people we're interested in. We're going to spend a lot of time talking about what is day one. We can't necessarily enroll someone in an observational study, but we can approximate it, and do our best to get there. And then we're going to try and deal with all this confounding that always plagues observational data. We're going to have well-defined outcome measures. They did all that stuff, and they asked a super relevant question, which was, in RA-ILD, we have all these drugs that these new guidelines have recommended. What about just using the normal therapies? How do they perform? So they said, we're going to look at Medicare A, B, and D, and they're going to get all the patients they could with RA-ILD using a bunch of validated coding algorithms. And they said, we're going to look at, compared to rituximab, how did patients do who got abatacept, tocilizumab, a JAK inhibitor, or a TNF inhibitor? So a really cool clinical question. We're looking at all the good things for RA, and we're comparing it to rituximab. Their index date was the first date after you got the ILD and you got your biologic or targeted synthetic DMARD. And then they did the fancy propensity score matching to try and adjust for confounding. You can never fully get rid of confounding, in my opinion. There's a bunch of ways to try to measure that, and this group is expert at doing it. But just so you know, it's not a magical solution, but it's the best effort we can do. And then they said, we're going to look at hospitalizations for respiratory issues, transplantation, or death. So a bunch of outcomes that we really like and care about. And what did they find? There was just absolutely no difference on for their composite outcome measure. So if you got abatacept, an IL-6, a JAK, a TNF, or rituximab, your RA-ILD didn't seem to result in badness in any differing amount. Now, once you start slicing and dicing things, the story got a little bit weirder. And actually, JAK inhibitors and abatacept looked a little bit better than rituximab, which is completely the opposite of where some of the recommendations had come from those recent ACR guidelines. Now, EULAR zagged, and they included some of those. So I think that there's some increasing awareness that some of these other mechanisms might be good. But my summary is really from the presentation. This is what the gentleman who gave the presentation said. And I really thought this was well put. He said, achieving good control of disease activity is probably the key objective of treatment of patients with RA-ILD. I just really like that. I think that if you're going to be treating RA-ILD, your prior should be that we're going to use a drug that works for RA. So I don't know. What do you guys think? Do you feel good about that? How do you feel about observational data to answer causal questions? Akil, I'm going to go to you first. What do you think, Akil?
Yeah, I think that's really interesting. I mean, I think definitely when you think of the sequence of therapies, you think like rituximab is going to be the superior, the later line agent. But then when you're seeing these findings of the abatacept and the JAK inhibitor in RA-ILD, I think it really then boils down to is just, yeah, treat the target and getting the disease under control. And then if you can control the rheumatoid arthritis aggressively within joints, you can avoid progression outside the joints. And even when you have RA-associated ILD, be interesting to see where exactly, yeah, I think that, yeah, it was really interesting, just how they can get the treat to target within control. And that's better, the similar outcomes. Yeah.
Brian, where are you at on this? What do you think?
So remind me, Mike, and you may have mentioned this, when they're propensity matching, are they matching also based on like severity of ILD in these folks? Like, do we know where they
Yeah.
balance between treatment arms groups? Because presumably if
Oh.
you're getting rituximab, you're thinking of like people with sicker disease.
Yeah, the plot thickens, right? So, in their abstract, they went over their propensity. So, the nice thing about propensity matches, you can look at a whole bunch of variables, and they have
Mhm.
like over 40 or some. But this is Medicare data. You don't have like really granular FVCs. You don't have a 6-minute walk test for these people. And so, yeah, I mean, you found the fly in the ointment here. This isn't the kind of data that you can be like 100%. We knew exactly what these patients had. And when I said you can't always fix things with propensity matching, part of the problem is you can't always match, or if you use inverse probability weighting, which is a similar approach, you can't always have all the variables. I always joke about acai berry consumption and yoga participation. Like, we never know how much people participate in yoga, but maybe it's really bad on one side. And the beauty of randomization is that you fix all of those. And I think you keyed in on a key point, which is that, there's some things they couldn't really fix, and maybe that's part of the problem here. So, good epidemiology coming from Brian here. All right, I'm gonna
That's a
throw it back to you after you. Sorry.
I was gonna say a phrase I don't know if I've ever heard before, so thank
No, no, you got right to the crux of the matter and rained on my little target trial parade, which is very appropriate. And I think that's a very important limitation I forgot to mention. All right, so let me throw it back to Brian here. Tell me about your next abstract. What are you excited about, Brian?
Yeah, so actually, somewhat in the same vein when we think about propensity matching and observation. So, this is abstract 2689. It was in the psoriatic arthritis abstract session today. It's comparison of incidence of PSA in patients with psoriasis treated with a variety of different agents, IL-17 inhibitors versus 23 versus 12 and 23 versus TNFs. And this was a retrospective study by April Armstrong and their group. So, of course, this tries to address or give us information about a really interesting question, which is who with psoriasis progresses to psoriatic arthritis? Are there certain treatments that we should be giving people or dermatologists should be thinking about upfront that will prevent progression to psoriatic arthritis or maybe just treat the joints better? And so this was a retrospective study. They tried to capture a very specific patient population. So they had to have a diagnosis of psoriasis without having ever started any kind of biologic treatment. So they were biologic naive. And the chart was, scanned for no diagnosis of PSA. They gave a 14-day grace period. So if within 14 days after the index date, they were diagnosed with PSA, it was accounted for that they may have just not seen a rheumatologist yet or something like that. And they basically matched cohorts compared to the last group, where rituximab kind of served as the comparator, IL-17 served as the comparator here. And they reported the results as percent time with psoriatic arthritis per agent exposure. So in all of the groups, numerically speaking, IL-17s seem to perform the best. They had numerically less time with psoriatic arthritis. That only reached statistical significance when IL-17 was compared to the 12-23 combo or versus TNFs, not versus 23, though it came close. Um, and similar to what you were mentioning before, tried to control for confounders with propensity matching based on psoriasis extent, the subtype of psoriasis that they've had, the disease duration, background DMARDs. Again, not perfect, but at least trying to, take some of these other factors out of it. I think a big limitation here, and, was definitely mentioned in the presentation, is that these patients are often with psoriasis, PSA, not staying on one agent for a very long time. And when they switch to another agent, they drop out of this study. And so you see they start with really large numbers at the beginning in the first year. There's like, around 1,000 people, for example, in each arm. By year one, that gets cut at least 50%. And by year two, you're talking like double digits of the number of people. And a lot of the time when you get to year two, that's when you start to see the separation curves of people who are getting PSA between the two treatment arms. And so you wonder like how much is all this dropout and treatment switching, creating an effect that is not actually, causal, but, associative. Um, so anyway, I think it's interesting. I think I'm always trying to ask, the question of anecdotally see when patients come from derm, what biologic they're on and trying to make my own associations of what I see the most of. But I'm curious to hear from you all. And I know, Mike, you probably have some thoughts on this from your own work. What your takeaway from this is?
Yeah, I'll let Akil jump in first, and then I'll share some thoughts on my own here. Akil, what do you think about this? Do you have a favorite? Do you believe it? Where are you here?
Yeah, no, that's a good question. I mean, I think, for me, I think when I see patients, I guess with psoriatic arthritis, we often think of the TNFs first, but I think it's interesting when you're seeing that this IL-17 is having better data compared to the TNF versus the IL-12/23. And I think, Brian, you brought up a really good point, is that this, within this window, there's lots of switching, discontinuation, and that could be a factor that is kind of confounding this. And I think I think definitely that the timing or switching of the medication could be one thing. And then, I think also thinking about which biologics work best on the skin domain is also a big factor as well. I mean, IL-17 I think does work well, like IL-17 and TNF work well for joints, um, versus like 12/23, and that could be a component that could be, confounding it, but definitely it's interesting as well.
No. So Brian was joking because I have done work in this area before. I was a co-author on a paper with Shika Singlo that looked at this particular question. And we saw that IL-17s were not better than TNFs, but the 23s and 12/23s might be. So this goes back to what I started with a little while ago about the perils of observational research for causal inference. You just need randomized controlled trials. And the nice thing about this area is that there actually are enough trials. It'd be kind of neat if we could pool all that data and kind of get into it. But yeah, it's going to be an ongoing debate, and I think this is a good research group. They know what they're doing, and so this is definitely going to throw some gasoline on that fire. That was a great one, Brian. Thank you.
Thanks.
Akil, you're up with another one looking at lupus nephritis. I love it. What's going on in the world of lupus nephritis?
Yeah, yeah. So there were two abstracts in the SLE treatment session earlier today, and and it was really interesting that they're looking at the use of tacrolimus versus MMF plus tacro, or MMF alone in lupus nephritis. And there was abstract 2697 and abstract 2698. And so abstract 2697 was a prospective randomized control trial that looked at the efficacy and safety of tacro versus mycophenolate, in both cases receiving glucocorticoids in the induction and maintenance remission for proliferative lupus nephritis. And their primary endpoint was looking at sustained renal response by week 96. And the sustained renal response was defined as at least 50% reduction in proteinuria and 24-hour urine protein less than 1 gram, and no rise in creatinine at least 15%. And they also evaluated the safety as well. And this was a trial that was composed of 130 patients, 65 in each group. And so when they're comparing tacrolimus versus mycophenolate, both groups actually showed similar rates of sustained renal response at 60% in tacrolimus versus 70% by week 96 in the mycophenolate group. And then the time to renal adverse events were actually similar in both groups at a rate about 70%. And then there's another abstract 2698 that took a different approach and alluding to the target trial emulation, nicely described by Mike, that was comparing tacro versus tacro and mycophenolate combination in patients with proliferative lupus nephritis. And so this one, they looked at the primary outcome was the total renal response, which is complete or partial renal response by 12 months. And they also looked at the safety as well. And so in this one, they actually showed that compared to the combo of mycophenolate plus tacro, the tacrolimus group had a much lower rate of total renal response at 33% versus 60%. And both in the intention to treat and per protocol analysis, or the equivalent of that, they use an emulation of a target trial, the tacro plus mycophenolate showed significantly higher total renal response. And so I think just overall, just really interesting is that the one abstract was showing that tacro alone versus mycophenolate, there was similar efficacy, but when you look at the combination of mycophenolate plus tacro, it was much superior in terms of efficacy, um, and similar safety. And so, kind of alluding back to the guidelines that were released last year, I think I would still say in the terms of guidelines, I would still favor the triple therapy of mycophenolate plus CNI if patient has elevated proteinuria. But curious to hear your guys' thoughts as well.
And I gotta say, this made me uncomfortable. And here's why. Because Vocalosporin was fine, but it wasn't really this good. Is it possible we picked the wrong horse and it should have been Tacro all along? I don't know. I've always been kind of excited about Tacro. I like Tacro for myositis, and I've kind of long thought that it'd be maybe a good addition in lupus. And then the vocal spout trials kind of, they confirmed that, but then we went Voclo and it wasn't that strong. So I don't know. It gives me the heebie-jeebies. Brian, what do you think?
Man, I have to say I'm not a tacrolimus lover.
Oh
So,
no.
so for me, I mean, listen, I think in lupus it's just hard because it's not treating a lot of good stuff in lupus other than the kidneys. And so I like that Cellcept, or mycophenolate gives you much broader coverage. I agree with Akil, that this is mirroring our guidelines of triple therapy. And I think that's reassuring to see like another trial that, supports what we're doing. But between Tacro and Voclo, I think I'm still on board with the Voclo train. I haven't sold my ticket yet.
Uh,
Yeah.
uh, calcineurin non-exciter guy over here. I get it. I get it. I get it. Yeah, I would not favor Tacro over MMF if it's monotherapy. That's for sure.
Yeah,
No.
All right,
absolutely.
I'm going to end with a quick hit here. This is a late breaker number 20. This is important data. This is the efficacy and safety of deucravacitinib up to week 52. So this is from the Poetic trial program. Deucravacitinib is a TYK2 inhibitor. It's kind of a cool mechanism. We had our whole run of JAKs, and now we're all kind of bored of JAKs, and we're moving on to the newer, fancier, shinier things. And I think the TYKs are kind of coming on strong, and deucravacitinib is I think the first to the party, really. And so they're investigated in psoriasis. They're approved in 2022, and then this is their TYK2 inhibitor deucravacitinib that was they're showing their data of 52 weeks for psoriatic arthritis. Now, the trial only ran for 16 weeks in a blinded fashion. At first, I kind of like looked askance at that, but then I remembered that you can't untreat people for 52 weeks for active psoriatic arthritis. So 16 weeks seems like a reasonable time point. It looked pretty good over 16 weeks. Pretty nice benefit. Patients in the deucravacitinib group had higher PASI 75s. That's a skin score, as you would expect. But DAS28 CRP scores were better, and there's about a 20% difference in the ACR 20s. So about number you treat 5 people to get an ACR 20 at 16 weeks. Not bad. They did an open label, and everyone just sort of drifted up and found their little happy place. So overall, looked pretty good. Pretty encouraging. I bet they get the label for psoriatic arthritis, and then we're gonna have to decide what to do with it. So, do you guys have any early hot takes on where TIC2s are gonna fall into your treatment paradigm? It's a pretty crowded place. We've got Jacks, 17s, 23s ish, TNFs. Where are you gonna put it, guys? Brian, I'll go to you first. What do you think?
Yeah, I imagine. So I don't think we're seeing the same safety signal that the Jack
Mhm.
saw. And so I
Okay.
imagine this is not coming with the black box warning that the Jack has. So I'm wondering if the place is going to be a patient who prefers an oral agent, hasn't necessarily failed a TNF or something, allowing us to get a Jack, but this is maybe in our armamentarium as a potential first line that we can use for those patients who really just do not want to, take an injection or infusion.
Pretty sharp hot take. I like it. Akil,
Yeah.
what do you think?
No, I completely agree with Brian. Is that I
Yeah.
think definitely like individual that prefers an oral formulation over injectable or infusion, I think is definitely one thing. And then even looking at the JAK inhibitors, I think just the safety profile, the black box warning, and then the strong association of metabolic comorbidities in psoriatic arthritis or psoriasis as well. I think I would definitely place a TIC2 above a JAK, but definitely each is a case by case and risk versus benefits. But I think these findings are really promising and really exciting as well. And definitely, I think there's some promise with the TIC2, and I think it'll be a great option for our patients as well, especially those looking for an oral option too.
I love it. Very promising and some great options for patients. I think that's kind of a good theme for today. We had a lot of interesting new drugs and kind of a lot of good reports, observational studies. Kind of reporting on some of the older drugs, whether or not, which who knows which ones were correct. So, I think that wraps up our day 4 coverage. So, thank you to everyone who tuned in. I really appreciate y'all following our coverage at Room Now for the last day of the meeting. This does not end our coverage, though. So, if you're looking for a very spooky way to stay connected to ACR25, Artie and Jack will be hopping on the podcast Halloween. That'll be this Friday. I certainly expect them to be wearing costumes. And then next week we'll have a lot more great content. There'll be a bunch of content panels, the Axpa, Spa, Psoriatic, CAR T, of course. And then, most importantly, if you are available, please sign up for Room Now Live in Dallas, Texas. That'll be February 7th and 8th. I will be there talking. I would love to see you all in Dallas, Texas, and would be a lot of fun to have a big crew at that meeting. So you can register now at roomnow.live. But that's the last thing I've got. I want to thank both of our panelists. Thank you, Brian. Thank you, Akil. Thank you for joining us. Appreciate having this conversation with y'all.
Awesome. Thanks, Mike. Great to be here.
All right,
Yeah.
thank you.